So hello everyone, I am Dr. Ankit Goel, your Psychiatry faculty. Today in this video, we are going to discuss INI-CET November 2022 questions of Psychiatry. So let us begin with our discussion. Now, before starting, let us try to analyze the paper related to Psychiatry questions. Now, if you could see again, substance use disorder had a lot of questions. So in both morning and evening session, if we combine, around 4 questions were there from the substance use disorder. As we have already discussed, even in our revision session, substance use disorder is very important. Then there were around 2 questions on epidemiology. Now nowadays, if you see the pattern of INI-CET exam, a lot of questions have been asked from epidemiology, and even this time there were 2 questions which were on the epidemiology. So nowadays they are not focusing on the topic itself, but on a certain aspect of the topic. Okay, now psychopharmacology, as we always say, even in our lectures, becomes an important part of the exam. So around 3 questions were there. Then there was a question on OCD and impulse control disorder. There was a question which we will be discussing. Paraphilias again is a very common topic which has been asked repeatedly. Again there was a question, and there was a new question as well. Now generally, when we see a new question, we tend to get nervous, but as we'll discuss, sometimes even if you apply some logic or some common sense, we are actually able to solve the question. Now, so there were a lot of repeat questions, or the repeat topics were there. So if you ask me, I'll say severity wise, the psychiatry portion was between mild to moderate, you can say. And yes, if you see the questions, evening I would say was slightly tougher than the morning session, right? So let us begin with the first question. And in fact, before moving to the question, not only just we are going to discuss the INI-CET November 22 questions, I'll also be giving you lots of concepts and questions which can come in your future exams, let us say the NEET PG exam or even the FMGE exam. And also, certain questions may come in the future INI-CET exams as well, right? So let us begin with the first question. So the question is, which of the following is true about depression? Option A, adults, males equal to females. Option B, in children, boys more than girls. Option C, adults, females more than males. And option D, child, girls more than boys. Now again, as we already discussed the epidemiology of depression, the answer seems to be quite simple in this. Even if you don't know the data related to child, many times in these questions of epidemiology, you may not know all the options, but you may know the right option. So the correct answer is, in adults, females more than males. Let us try to understand some of the epidemiology of depression. And as you can see, even when we were discussing super revision of psychiatry, we had discussed one question on epidemiology which had come in the previous exam. So epidemiology again in the recent questions is very, very important. Now in depression, we say the lifetime prevalence is around 10.8%, and the mean age of onset is around 40 years. Okay, so in the middle age we see, and when we see male is to female, female is more than males, and in fact we say it is twice more common in females than males, right? Now in terms of bipolar disorder, when we discuss, okay, so in bipolar disorders we say the prevalence is around 1%. And also you can remember, even in schizophrenia, in general population, when we see schizophrenia, that is also around 1%. Okay, now the mean age of onset is around 30 years. So in the 20s and the 30s we see the onset of bipolar disorder. So you can remember it is slightly earlier, than depressive disorder. And we see bipolar 1 disorder occurs earlier than bipolar 2. And in bipolar 1 disorder, male ratio is as same as, so male prevalence is same as female, while bipolar 2, females is more than males. Again, this concept has been asked previously as well. So this is again important. In terms of children, if we see in depression, female and male or boys and girls is similar, but by the time person in the adolescent population, we see the trend shifting as an adult. So in adolescent we see it is females more having depressive disorder than males. So you can remember depression in children, it is equal, male is equal to female, right? Now since these questions are asked, let us try to club in some of the important disorders and see which is seen more in males, which seen more in female, because these concepts are asked a lot these days. So when we see females more than male, a lot of psychiatric disorders, especially adult psychiatric disorders, like depression, as we had discussed, bipolar 2 disorder, lot of anxiety disorders we see are more in females than males, okay, like panic disorder, agoraphobia, specific phobia, generalized anxiety disorder. In fact, even OCD is more in females than male, but again in children we have seen, so in childhood if we see OCD, it is slightly more in males. Again, this you can remember. Eating disorder of course is more common in females. Borderline personality disorder again is more common in females than males. And Rett syndrome, it is one of the important childhood onset disorder, psychiatric disorder, which is more common in females, and this question has been asked previously in the NEET PG exam as well, right? Now male equal to female, again we have discussed schizophrenia is one and bipolar 1 disorder. One important point again you can remember, out of the anxiety disorder, one anxiety disorder is equal in males and female, that is social anxiety disorder. Social anxiety disorder. So this way, when we compile this list, again it becomes easy for us to remember. So again, since a lot of questions have been asked based on this, so you can remember it like this. Then males more than females, a lot of the childhood psychiatric disorders, so like autism spectrum disorder, so we have discussed, except Rett syndrome. Rett syndrome is more common in females, and this has been asked. ADHD, SLD, Tourette syndrome, then conduct disorder, okay, and personality disorder, that is antisocial personality disorder, again is more common in males than females. So this is a this is a list. So whenever you're giving exam, especially INI-CET exam, try to remember some of these because these have been asked, okay. So this is the first question. Let us come to the second question. Again, this question has been asked, such questions have been asked multiple times in the exam. So the question is, a patient consumes alcohol every day for last 10 years. He didn't drink for past 3 days and now presents with tremors, seizures, hallucinations and altered sensorium. Which of the following is the treatment of choice? So there are, again, when we recalled question, so some students said that it was like multiple options are correct, and some of said that one option was correct. So we'll try to understand how the question might have been asked and how we could have answered, okay. First of all, let us try to understand what is the diagnosis. So if you see, patient is in withdrawal state and is having hallucination, seizure and altered sensorium. So altered sensorium, this suggests that now the patient has landed up in delirium. So the diagnosis is patient has delirium tremens. Very, very important. This is very, very important, has been asked multiple times in the exam. So alcohol withdrawal, again, if you see, similar question we had discussed when we are discussing, the super revision session, we had discussed a similar question. Now, so alcohol withdrawal delirium, again, if a patient is consuming alcohol continuously and suddenly stops, so he develops some withdrawal symptoms. Again, these withdrawal symptoms you should know, especially the time duration. So in the first 6 to 8 hours of stopping, the most common symptom of withdrawal is tremor, or the earliest is tremors, okay. If it continues, the withdrawal state continues, in the next 8 to 12 hours, patient may develop alcoholic hallucinosis. Hallucinations may start, and here auditory hallucinations are more common than visual hallucination. If the withdrawal state continues for another 12 to 24 hours, then seizures may set in. These are generalized tonic-clonic seizures, okay, or also known as rump fits. And by 2 to 3 days, 48 to 72 hours, or within 72 hours, one can develop delirium tremens. Delirium tremens, visual hallucination is more common than auditory hallucination, right? And again, one important point to differentiate between alcoholic hallucinosis and delirium tremens is, in delirium tremens there is altered sensorium. Patient is in a state of delirium. So again, this is a very important table. Please remember, a lot of questions have been asked previously and may be asked in the future as well. Okay, so if we see the diagnosis in this case is delirium tremens. Now they're asking the treatment. So patient is in withdrawal state, right? So in the alcohol use disorder, whenever we treat, so we treat it in two phases. First is the detoxification phase, wherein we treat the withdrawals, and then there is the maintenance phase. Okay, now in the detoxification state, so alcohol is a suppressant. Suddenly the person was consuming it regularly, and suddenly the person has stopped consuming the suppressant. So brain is in a hyperactive state, which is leading to these withdrawal symptoms. So now we are going to replace alcohol with another suppressant. So drug of choice for alcohol withdrawal delirium is benzodiazepine. Okay, benzodiazepine. So there are a lot of benzodiazepines which we can use, like lorazepam. It is one of the short acting benzodiazepine. Then there are long acting benzodiazepines like diazepam, chlordiazepoxide. Okay, these are some of the benzodiazepines which we use. Okay, so this is again important. Also you can remember, a lot of time the concept is asked, sometimes in alcohol, patient consuming alcohol comes to you with withdrawal state. Patient may also be having deranged LFTs, or there may be some liver disease might have started. So in that case, which benzodiazepine we may use? Okay, so again benzodiazepines like lorazepam, okay, L for lorazepam, L for liver safe, okay, can be used. Okay, and another benzodiazepine like oxazepam, these can be used. Okay, because these undergo only oxidation, they are metabolized only with oxidation, while diazepam, chlordiazepoxide, they undergo glucuronidation and then oxidation. Again, because of liver disease, that may not be properly done. So these are lorazepam, oxazepam, these are some of the benzodiazepines which are safe to use in liver disease. Okay. Now along with benzodiazepine, one should also add thiamine. So chronic patients consuming alcohol, a lot of time we see there is deficiency of thiamine, and deficiency of thiamine can also lead to certain neurocognitive disorders like Wernicke's encephalopathy or Korsakoff psychosis. Okay, so along with benzodiazepine, one should also add thiamine for the alcohol withdrawals. Okay, so this is how we manage the detoxification. Few extra points again, such questions, because a lot of questions have been asked on the management. Okay, so few important, one or two points you can remember, like when we start a patient on a benzodiazepine, let us say we have started, so we start with a higher dose to control the withdrawals depending on how much alcohol the person was consuming. Let us say we start with 10 or 12 milligram of lorazepam in divided doses, right? So first day we give this and we see if the withdrawals are controlled. Then second day onwards, we start reducing the benzodiazepines. So how much we reduce this, you can remember, we reduce it by 20% every day. We keep on tapering, and slowly when the symptoms keep on going, we gradually stop the benzodiazepine. So generally in 5 to 7 days, we generally taper and stop the benzodiazepine. So again you can remember how much reduction is there, 20% reduction from the first day. So first day you calculate and then gradually we decrease 20%. Again, this is an extra point you can remember. Coming to this question, so some of the students said that there were multiple options. So some students said there was one option was thiamine separately and diazepam was separately, and you have to choose one. So again, that means that yes, you can choose diazepam and thiamine correctly. Right. So please understand, along with this, since we tend to get confused what to mark. Now please understand, so we know benzodiazepines and thiamine is the drug of choice. Okay, so benzodiazepine is the drug of choice, and then we can add thiamine as well. Now sometimes we can also give carbamazepine. Sometimes carbamazepine is also used for the management of withdrawal. Carbamazepine is not used for its anti-epileptic property here. We are not using it as an anti-epileptic agent, but we are using it for treating the withdrawals. Okay, so sometimes carbamazepine can also be used, and along with this, sometimes if the patient has very severe agitation, patient is very severely agitated or severe symptoms are there, sometimes then we can use low doses of certain antipsychotics like haloperidol. Okay, like haloperidol. Okay, they can be used, but yes, not for, no, we're not using it for managing, alcoholic hallucinosis. For, please remember, for alcoholic hallucinosis or for seizures or for delirium tremens, the treatment is benzodiazepine. But yes, sometimes we can use these agents, so please remember, but drug of choice would be benzodiazepine. Okay, so this is the question. I hope it is clear. Right. Now, along with this, please remember, delirium tremens especially, now please remember, it's a medical emergency. We can lose the patient, if it is, untreated, in untreated delirium tremens, 20% patient may die. Okay, so it is again medical emergency. And delirium tremens generally when develops in a patient, of course it develops in, it's a severe withdrawal, but when it develops, one should also look for certain other possible causes. So it occurs, when patient may be having some concurrent medical illness, like person is having pneumonia, renal disease, hepatic insufficiency is there, heart failure is there, infections is there. Again, both these questions in fact have been asked, in your AIMS exams. A delirium tremens, again, it may be precipitated with, someone having hepatic insufficiency or infection. Both these questions have been asked separately in your previous AIMS exam. Okay, so again, this point you can add on. Okay, next question. Again, related with the treatment. Now, all of the following are true about disulfiram except it's an alcohol dehydrogenase inhibitor. Initial dose is 250 milligram. Accumulation of acetaldehyde leading to nausea and vomiting. It doesn't reduce craving. Now, many times, when you get such questions and many, times doses are given, try to see, you may not know all the options, but you may know the right answer. Okay, so and I'm sure, if you talk about disulfiram, we know what is the mechanism of action of disulfiram. It is a acetaldehyde dehydrogenase inhibitor. Okay, so this is incorrect statement. Okay, this is incorrect statement, so this is the right answer. Okay, even if you don't know other, few of the other option, this one is absolutely wrong, so this is the answer. Let us try to understand again, this point we had discussed when we were discussing, psychiatry in the revision session. Again, we had discussed this. If you see, okay, this is, so if you see disulfiram, if you see, we have discussed it's a acetaldehyde dehydrogenase inhibitor. Okay, so let us talk about the maintenance. Okay, so we talked about detoxification. Again, I'm discussing this topic again in detail because this is very, very important. Okay, so in maintenance, basically we have treated the withdrawals and now we want that patient may maintain this, sober state. Okay, so there are various mechanisms. One is we use certain anti-craving agents. We use certain anti-craving agents. Two important anti-craving agents you should know is, first is acamprosate, which is a NMDA antagonist. Okay, it's a NMDA antagonist. And another important anti-craving agent is naltrexone. Okay, naltrexone, which is again, what is naltrexone? It is a mu opioid antagonist. Okay, so these are two important anti-craving agents which we use for maintenance. And then again, another strategy is when we use drugs like disulfiram. Okay, disulfiram. So let us try to understand, what is the, what happens, when we're using disulfiram. So please remember, this disulfiram is not an anti-craving agent. We've discussed, anti-craving agent. These are the two anti-craving agent. It's not an anti-craving agent. It's a deterrent agent. Let's talk about disulfiram. Now, if you look at the metabolism of alcohol in the body, so what is there in beverage alcohol? If I ask you, so it is basically ethanol. So how it is metabolized? It is metabolized to acetaldehyde, and then it is metabolized to acetic acid, and then forward to carbon dioxide and water. Now, what are the important enzymes, okay, related in this reaction. Now from alcohol to acetaldehyde, it is the alcohol dehydrogenase, and acetaldehyde is further metabolized to acetic acid by this enzyme, aldehyde dehydrogenase. Okay, aldehyde dehydrogenase. Okay, now basically disulfiram is inhibiting this enzyme, aldehyde dehydrogenase, ALDH. It is inhibiting this enzyme. So what will happen? So person is taking disulfiram daily, and when the person consumes alcohol, what will happen? There will be accumulation. There will be accumulation of acetaldehyde in the body, and acetaldehyde, accumulation leads to unpleasant symptoms. Okay, like patient may complain of nausea, vomiting may be there, flushing may be there. Okay, there may be tachycardia may be there. Okay, these are the symptoms. So what message the person is getting? That he is taking disulfiram daily, and whenever he consumes alcohol over it, his body is having some unpleasant symptoms. So basically he is getting a message that whenever I consume alcohol, I get these unpleasant symptoms, so he may not consume alcohol. So what is disulfiram then? Basically disulfiram is a deterrent agent, or it's an aversive agent. It is not allowing the person to consume alcohol, it is aversing the patient towards alcohol. So it's a deterrent or a aversive agent. Okay, it's a deterrent or a aversive agent, again important. And generally the usual dose is it's 250 milligram per day, 250 milligram per day. So this is the mechanism of action of disulfiram. Okay, so again if you go back, let's go back to that question. So we know it is a aldehyde, it's not a alcohol, it's a aldehyde dehydrogenase inhibitor. Okay, so this statement is wrong. Okay, and we have to choose the wrong statement. Now initial dose is correct, accumulation of acetaldehyde which leads to nausea and vomiting, again that is correct, that is the aversive action it is producing, and it does not reduce craving, correct. Okay, it's not an anti-craving agent. Okay, so again the correct answer is A. So please try to see, many a times you may not know all the options, but you may know the right one. So don't get nervous when you see such questions. Now next question, again a psychopharmacology question. Those who have attended the live classes, we discussed this in detail. Okay, so which of the following is true about memantine? Okay, so memantine dose is 15 to 20 milligram per kg. It's NMD antagonist, used in alone and not in combination with donepezil, metabolized by liver. So these are the options. Again, if you don't know all the options, I'm sure you know the correct statement. Okay, what is memantine? What is memantine? Basically it's a drug used for treatment of dementia, and we know the mechanism of action of memantine is similar to what we have discussed with the camproside. It is also a NMDA antagonist. Okay, NMDA antagonist. So let us try to discuss some of the important treatment modalities with dementia. Now in dementia, especially Alzheimer's disease, I always say, always try to correlate etiology with the treatment. Once you start doing that, once you start forming that concept in psychiatry, things become very easy. Now in Alzheimer's disease, we have seen that there is decrease of acetylcholine in the brain. Okay, also yes, there is decrease of even norepinephrine, and it is seen that there is an increase of glutamate. Glutamate is neurotoxic, so excessive glutamate again is causing damage to the neurons. Okay, so these are important neurotransmitters which are implicated in Alzheimer's dementia, right? And also if you know in pathology, microscopic findings, one of the important microscopic findings are the amyloid plaques or the senile plaques or neurotic plaques which are seen in the brain. Now in this single slide, we can discuss three important mechanism of action of drugs. So always try to correlate. Now we know there is a decrease of acetylcholine. In fact, this concept had been asked previously in one of the FMGE exams. They had asked elderly male having Alzheimer's disease, which of the neurotransmitter is decreased. So you know that acetylcholine is decreased. Even if glutamate is there in the option, glutamate is not decreased, it is increased. Okay, so we'll use certain drugs which will increase acetylcholine. So you can remember with the mechanism of action of drug, you can remember the etiology. We will use certain drugs which will be which will, you know, decrease glutamate or maybe antagonist to glutamate, and then we'll discuss another newer modality. Okay. So in dementia, you know, first are the cholinesterase inhibitors. Cholinesterase inhibitors, basically acetylcholine is broken down into acetyl and choline by this enzyme, cholinesterase inhibitor. Okay. Now if you inhibit this enzyme, what will happen? There will be increase in the acetylcholine. Okay. So this is what we want, this is what is required. So this is one group of drug. Now under this there are some important drugs. First is tacrine. One should know, you know, one should know that tacrine is no longer used. It is banned. It is banned because of hepatotoxicity. It is hepatotoxic. Okay, it is banned because it is hepatotoxic, right? Then other drugs like donepezil, rivastigmine and galantamine, again important drugs which we use, which belong to this category, cholinesterase inhibitor. Then so basically acetylcholine we are trying to increase. Then we know glutamate is increased, so what we do, we use another drug which is mementin. Okay, so what is the mechanism of action of mementin? It is a NMDA antagonist. What is NMDA? These are basically glutamate receptors. Glutamate receptors. So we know the glutamate is increased. We are using NMDA antagonist, okay, for the treatment. Okay, and generally mementin we know is used for moderate to severe cases. Okay, it is used for moderate to severe cases. Again, you know, when we talk about the dosage, we generally start with 5 milligram per day, and gradually we may increase to 20 milligram per day. So up to 20 milligram per day we can increase, and we can give it in divided doses as well. Okay, so this is important. Another important point is that a lot of time mementin is used in combination with donepezil. Okay, it is used in combination with donepezil. In fact, there are formulations present which are, you know, which are combination of mementin and donepezil. So yes, it is not just used alone, it can be used with combination also. So again, important, it can be used. Now some of the important serious side effects, you know, again adverse effects. One is it can lead to seizures. One need to be careful if a person already has a seizure disorder, and also it can cause bradycardia. Okay, so these are some of the other important points which you should remember. Okay, now let us talk about another modality, relatively new. So there is a new drug which although has been approved by the FDA, so I'll talk about, you know, briefly about this new drug. So we have discussed one more important, you know, thing which was happening was there were amyloid plaques which are getting deposited. So we have a new drug, aducanumab. From the name itself you can see the mechanism of action. It's a human IgG1 monoclonal antibody, MAB. It's a monoclonal antibody. Okay, now basically it binds to the A beta aggregates, okay, and helps in the clearance. So you know, a lot of research has been going on with certain other mechanism of action, and this one is very important. Many drugs have been, you know, being under trial for, you know, this mechanism of action. Okay, so basically it helps in clearance. Okay, so you can say it's a targeted therapy. Okay, and it is given as a once a month IV infusion. Okay, and it is used especially for, it is being used especially for what? It is used for Alzheimer's dementia. So you can remember from the name AD, it is used for Alzheimer's dementia, and it's a monoclonal antibody. So although it has been approved, but again, you know, in the you know, when the drugs is being given and more trials are done, you know, efficacy is still not very clear. Okay, so but although it has been approved and it has been used in the US, it is being used, but still efficacy is not clear. But it is a new drug, and maybe similar drugs may come in the future as well. Okay, so this is about important about the drugs for the management of dementia. Now let us go back to the question. So we know true statement is this. Okay, maintenance dose is this? No, it's very high which they have given. We have discussed maximum up to 20 milligram a day we can give. Okay, it is used in alone and not in combination. Again, this is not correct. It is, in fact, we have a lot of formulations which have a combination. Okay, it is metabolized by liver? No, it is metabolized by kidneys. It is renal metabolism. Okay, it is renal metabolism. Okay, so even if you don't know few of these points, you know the mechanism of action. This is, if you see regularly, a lot of questions come like this. You may not know all the options, but you will know the right one. So don't get nervous seeing such questions. Okay, now let us come to, again, this is one of the common repeat question which has been asked many a times now. Even in your FMGE exam also this question has been asked. So a chronic smoker wants to quit smoking under psychosocial support. Which drug can be used? Again, let us talk about the treatment of tobacco use disorder. Again, in the revision session we had especially taken up this question, and there itself I have told you, which drug is more efficacious. Okay, let's try to understand. So when we talk about tobacco use disorder treatment, one strategy is NRT that is nicotine replacement therapy. Okay, NRT can be used wherein we have certain nicotine replacement agents like gums, lozenges, we have patches, there are inhalers and even nasal sprays. These can be used. Then we have certain anti-craving agents. Let us try to understand some of the important anti-craving agents. So first is varenicline. Okay, varenicline. What is varenicline? Again, you should remember the mechanism of action. It is a partial agonist of alpha 4 beta 2. I always say 4 is first, 2 is later. So alpha 4 beta 2 nicotinic acetylcholine receptor. Okay, so this is a mechanism of action you should know. Now it decreases craving and it also decreases withdrawals. Okay, it not just decreases craving, it also decreases withdrawal. Now few important points about varenicline. When varenicline, initially when varenicline was used, there was a black box warning. There was a black box warning that it increases neuropsychiatric symptoms, especially suicidal tendencies. Especially suicidal tendencies. Okay, so there was a black box warning that it increases certain neuropsychiatric symptoms like suicidal tendencies. But now in many of the further studies it has been seen that this may not be correct. This may not be correct, but again this warning is still there, but it has been seen that it may not be there. But another black box warning. So another black box warning with varenicline which is there is that it can cause cardiovascular adverse effects. Okay, so this is again important. Okay, so it can cause these, so again, one having cardiovascular disease or cardiovascular abnormalities, one should be careful using varenicline. Okay, and so this is varenicline. Then next is bupropion. Bupropion, it's an antidepressant. It's a norepinephrine dopamine reuptake inhibitor. It's an NDRI. It's an antidepressant. This question has been asked also. And antidepressant for smoking cessation, that is bupropion. So we have three strategies. If you see, we have NRTs, varenicline and bupropion. Of course, all these are good, drugs. They, increase the cessation. But if one asks you which is the most efficacious, again, under a lot of studies, it has been proven that varenicline is the most efficacious. So this is again very, very important. It has been found that varenicline is one of the most efficacious drugs. Okay, so let us come to the question. So again in the question, varenicline and bupropion both are used, for tobacco or smoking. Mirtazapine, trazodone, these are again antidepressant, but we know A and B both are used, and if you have to choose one, we'll go with varenicline. Again, it's a repeat question, direct repeat question, again very important, please remember this. Now coming to the next question, again we had discussed this. Again this question has come: a patient of alcohol dependence with deranged LFTs come in withdrawal state. We have talked about this. Which is the treatment of choice? So we'll use a benzodiazepine which is safe, in liver disease. Okay, safe in liver disease. So one we know is lorazepam. One we know is the lorazepam and oxazepam. So there was a question previously on lorazepam. Now they have not given lorazepam, they have given oxazepam. So the correct answer is oxazepam. I hope this is clear. Now match the following. Again, paraphilias, again very common repeated question which has been asked in the exam. So so let us talk about, so what is frotteurism? It is touching or rubbing the non-consenting partner. Exhibitionism, as the name suggests, exposing genitalia to strangers. Necrophilia, sexual pleasure with the corpse or the dead bodies. And eunism, wearing female clothes by male. Okay, let us try to talk about, so since we are discussing this, let us try to talk about some important paraphilias or perversions. Basically, these paraphilias or perversions are deviation from the normal sexual behavior. So these are deviations from the normal sexual behaviors. The first is fetishism. There is fetish, or sexual focus or sexual gratification is towards objects like shoes, gloves, or through non-genital body parts. Okay, this is also known as partialism. You should also know these, common alternate names. Many times they have been asked in the exams. Okay, then second is exhibitionism. I always say, remember, a lot of these terms you can remember from the name. So exhibition, exhibitionism is exhibition, urge to expose genitals to strangers or in public, through which the person is getting sexual gratification, okay, or sexual pleasure. Okay, so exhibitionism. Then frotteurism, touching or rubbing the against a non-consenting partner or in public. Okay. Voyeurism, observing, unaware people, in certain activities like they are undressing or while they are engaging in some sexual activity. So person is getting sexual pleasure by observing the other person, okay, who is, either undressing or is engaged in some sexual activity. This is also known as scopophilia. Okay, you should also remember some of these, alternate names. Then transvestism. Transvestism, so person dresses in opposite gender clothes for sexual pleasure. For sexual pleasure. Okay, so if an eonism is basically a term when a male dresses like a female. Okay, then masochism, so person derives sexual pleasure while, being humiliated or hit or suffer or is made to suffer. Person develops, derives sexual pleasure. This is masochism. While sadism is when patient derives sexual pleasure by, suffering or humiliating the other person on someone else. Okay, you can remember it like this. M is on myself and S you can remember on the second person or the other person. So you can also, so that you don't get confused, you can remember it like this. So always good if you, have these tricks so you can remember it like this. Okay, then pedophilia, again as the name suggests, sexual pleasure, sexual gratification with indulging in sexual activities with the children. Necrophilia, necrophilia again as the name suggests, sexual pleasure through the corpse or the cadavers or the dead bodies. Okay, so this is about the match the following. So let us go back. I hope this is clear. So A is 2, B is 1, C is 4. So this is the correct answer, right? Now let's talk about the next question. Lithium, again lithium is a very important topic, one of the important drugs. Lots and lots of questions have been asked on lithium. We'll try to discuss some of the important questions. Okay, so lithium levels in patients for treatment of acute mania and for prophylaxis of mania. So they're asking, so now, so some, they've just twisted the question. They asked, so we use, lithium when we treat mania in the acute phase also and also in the prophylaxis or the maintenance phase. The doses or the, therapeutic range may vary. Now again, lithium has a very short therapeutic index, okay, narrow therapeutic index. Okay, now and they've given various levels. Let us try to understand. So lithium, we say, so therapeutic range is 0.5 to 1.5 milliequivalent per liter. This is the therapeutic range generally we say. Okay, so for treatment this is the range which is required. Okay, again even in psychiatry books certain discrepancies are there in the levels, okay, that what is the range, okay. Like for acute mania, again this is, again this is, the level from the latest CTP comprehensive textbook of psychiatry, Kaplan and Sadok, which I am giving you the values. Again in that also some variations on the same topic they have given. So acute mania, the dose is somewhere around 1 to 1.5 milli equivalent per liter, and while for the maintenance the dosage may be slightly less, so it is 0.6 to 1.2 milli equivalent per liter. Again there may be some variations, okay, and more than 1.5 it leads to toxicity. So generally our approach is it should be less than 1.5, okay. So again if you see this question actually it is asking you what is the therapeutic range, because it's asking you both for acute acute phase as well as for maintenance. So we know the correct answer would be around 0.6 to 1.5 milli equivalent per liter, okay. 0.6 to 0.8 might have been correct for maintenance, right, and of course anything more than 1.5 generally may lead to toxicity. So these options are incorrect. So the correct answer is this, okay. Now again on lithium, before going to this, again on lithium, few other important points or questions which have been asked, you should know that this question again is a question which has been asked. So if you have to do lithium levels, patient is on lithium and you have to take the blood sample. When should you take the blood sample? This question again has been asked previously, okay. So you should take it 12 hours after the last dose, okay, 12 hours. So patient has consumed lithium, let us say 9 o'clock in the evening, okay, then you should take it 12 hours, 9 o'clock in the morning you should take the blood sample, okay, before giving the morning dose, okay. This is again, to be more specific, you can write down 12 hours plus minus 30 minutes, okay. So a gap of 30 minutes up and down can be there, okay. So this is again important. Again there was a question, so when the lithium levels is more than 1.5, so it leads to toxicity, okay, it leads to toxicity. A lot of GI symptoms and CNS symptoms are associated with lithium toxicity. There may be vomiting, there may be diarrhea, okay, there may be abdominal discomfort, then CNS there may be ataxia, myoclonus, and gradually if the severity increases the symptoms may worsen, okay. So generally there was a question, a patient is on lithium and patient is fasting, okay, and he has developed certain symptoms. So the certain symptoms like GI and CNS symptoms, what should you do? So please understand, whenever whenever a person is taking lithium, the body handles lithium like it handles sodium, okay. So body handles lithium like it handles sodium, both of them are elements, okay. So like let us say a patient is in a dehydration state, or let us say patient is having diarrhea, okay, or let us say patient is having excessive vomiting. So basically what the body tries to do, the body tries to absorb sodium, and also it absorbs lithium. So it leads to increase in the lithium levels, leading to lithium toxicity. So if in this condition, what will you do? What investigation you will do? You will check the serum lithium levels. Again, this question has been asked previously. This is again very, very important. And of course, one question which we discuss a lot of time, a lady, she is pregnant, okay, and if she is taking lithium, what teratogenic abnormality she may get, or the fetus may get? Epstein anomaly. Again, this question was there in your exam, but not not totally as a psychiatric question, but as a pharma question. We had to match the drug with the teratogenic effect again. So this question has been multiple times asked, so you should be careful while marking such questions, okay. So lithium is a very, very important topic. Please revise lithium before all the exams, very important. Then again, interesting question, okay, you have to match the following. Pyromania, what is pyro? Meaning of pyro, fire, okay. Kleptomania, what is kleptomania? It is stealing things of little value. Mutilomania, even if you don't know, see the name and see the option. Mutilomania, basically patient is having mutilating the body parts. And dipsomania, it is compulsive alcohol drinking. So let us try to understand again pyromania, kleptomania, we discuss, always discuss when you talk about this topic. Let us talk about impulse control disorders. Okay, in ICD-11, so we have ICD-11 now. Let us talk about some of the impulse control disorders. Similar to DSM-5, they have described it under disruptive impulse control and conduct disorder. First is pyromania. Basically what is happening here is person is getting a recurrent urge or an impulse which he is not able to control, and it is, the anxiety is continuously increasing and till the time it does not, does that act, the anxiety continues to increase. So this is what is happening in impulse control. The person is not able to control the impulse. So in pyromania, there is a recurrent urge of setting fire. Okay, he may go in the office, collect the wooden furniture and may set fire. It's not that because he's angry on his boss, because he's not able to control that impulse. Then kleptomania, it is basically stealing. So patient steals. Now here stealing is not for any monetary benefit, or patient is not using it for, stealing for personal use. The act of stealing is important because there is a urge to steal. Okay, so it may be a 1 rupee thing or it may be a 1 lakh thing. Is not using, purpose is not to use. So kleptomania. Then there is a new entity which has been added, compulsive sexual behavior disorder. So basically here the person has repetitive sexual urges. There is repetitive sexual urges, and then person indulges in some sexual behavior. So this is a new, this is a new entity which has been added in ICD-11. You can take note of this. And again, intermittent explosive disorder, this is similar to which is there even in DSM-5. Repetitive brief episodes of aggression, verbal, physical aggression, and it is out of proportion to the stressor. So there is some stressor, there is, let us say, some argument, but the aggression is much more out of proportion than the argument actually, the cause of argument. Okay, so this is intermittent. So intermittently patient is having some explosive episodes. Okay, these are some of the important impulse control disorders. Okay, then I know there is something known as oniomania. What is oniomania? Oniomania is compulsive buying. Okay, so these are some of the important impulse control disorders, right? So the correct answer here is A is 3, B is 4, C is 2 and D is 1. So the correct answer is D, right? So please try to see such short topics may come in the exams, right? Now this is a newer question which was asked. Okay, and again we got a lot of recollection, some again certain discrepancy in some of the options. Let us try to see the best possible options which you could get. Now which of the following is the correct definition of stress? Okay, now again in INI-CET such topics, again if you see in the past there was a topic on burnout. Okay, so such questions have been asked, but if you see the options, let us try to see the options and can we mark the correct answer. So they are trying to ask you what is stress. Okay, so first option, it's an adaptive response to a situation that result in physical, emotional and psychological state. That seems to be correct, isn't it? Stress is something which all of us have observed, all of us have experienced. Okay, we'll talk about it again. Let us see the options. It is mental tension. Yes, it is mental tension, but is it only mental tension? A lot of physical symptoms may also be there. Stresses can only be external and not internal. Now this seems to be incorrect. We know stresses not just are external, they can be internal also. Intra can be there, it's not always external. It is not based on your personality and experience. Again, if you read this option, it seems to be incorrect. Stress is something, all of us have different ways of dealing with stress. One same situation, all of us may deal it with different ways. Okay, so of course stress would depend on our personality and on our experience. So let us talk about it briefly. So basically, a lot of theories have been there, a lot of definitions. So Hans Eile, he describes stress as a non-specific bodily response, okay, to any demand caused by either pleasant or unpleasant conditions. So it can be both to a pleasant stimulus or an unpleasant stimulus. So stress is not just towards unpleasant stimulus. Okay, When it is towards pleasant, it is known as eustress. Some amount of stress is also necessary. You're studying, if there is no stress, you may not, study that well. So some amount of stress may be required for you to perform better. And when it is pleasant, then we call it as distress. So, and in fact, he gave a theory that is, gave a model, general adaptation syndrome, that, initially there is an alarm reaction. Then, in alarm reaction, a lot of bodily changes occur, then there is a stage of resistance. Now the person starts adapting to that situation. Okay, now the person is adapted to that situation, and then there is stage of exhaustion. That adaptation which the patient has acquired, then it may gradually be exhausted. So this is again a model given by Hansel. Okay, now any event is stressful or not, it is, again, it is determined by various factors. First is the nature of event, how severe the event is, it will determine whether it is stressful or not. And another important is, it is also dependent on person's personality, person's coping skills, how the person copes and person's experience. If someone has experienced a similar, stressor previously, they may adapt, or they may, now act in a different way. So of course, stress is determined by all these factors. Let us go back to the question now. So again, whenever you get such questions, I understand these are new questions. Generally, we don't discuss such topics in the classes. We have a limited time, right? But when you see such question, try to, apply certain logic and try to see if you can get the answer. As again I was saying, the first one seems to be correct. First option seems to be correct, no problem. Option B, again, somewhat correct, somewhat incorrect. Again, it is not totally correct. C is of course correct, incorrect, and D, again, it does not seem to be correct. So you have to choose one. The correct answer is option A. Okay, so sometimes, try to see and mark such questions like this. Okay, now next question, again an epidemiology question. A young girl, after the death of her mother, suddenly becomes blind but seems to be less bothered about her blindness. Which of the following is true about the condition? Now, if those of you who have attended my live classes, when we talk about this topic, if you remember, this is the exact similar, case scenario which I generally discuss in this case. A girl, her parents are, fighting, and they decide for divorce, and girl starts saying, I am not able to see. And she is sitting comfortably, but she says, I am not able to see. Now, first of all, we should know what is this. Okay, now this blindness does not seems to be a true blindness, or does not seem to be that there is some problem in the eyes or the brain. Okay, now there is a stressor. First of all, let us try to understand what kind of symptoms. So these are, certain disorders like dissociative disorders, somatoform disorders, conversion disorders. These are certain disorders in which there is the symptoms may appear, bodily in nature. The symptoms may appear, bodily symptoms may there. Like in this case, the person is saying that she is not able to see. Okay, but there is no anatomical cause, or there is no bodily cause. These are basically symptoms which are produced by the mind. It's not that the person is doing it deliberately. It is the mind which is, because there is so much stress. So basically mind is trying to decrease stress by converting stress into some of these symptoms. Okay, person is not aware that it is produced by the mind, and the person is not faking. Okay, what is this? First let us try to understand what is this scenario we are talking about, condition. It is conversion disorder. DSM-5 has given a very nice name to this disorder, a very apt name to this disorder. It's a functional neurological symptom disorder. The name is telling you there are neurological symptoms which are functional in nature. That means there is no organic cause. Okay, they are neurological symptoms which are functional in nature. ICD-11 places conversion of this type of disorder into dissociative neurological symptom disorder. Again, so it's put it under, the dissociative disorder list, and again, but if you can see, again, neurological symptoms are there. So symptoms are neurological with no bodily cause, no bodily cause. So if you, if this girl comes to you and, you're there in the emergency, they bring you that girl, you do, you call an ophthalmologist, call a neurologist, you do all the type of, investigations, examination, everything seems to be normal. The investigations or the examination all will seem to be normal. Okay, and generally, you know, there is some sort of stressor may be there, like in this case there is a stressor may be present. So when such type of, you know, questions come, you know, then you should think of these types of disorders. Okay, so conversion disorder. So again, in conversion disorder, symptoms can be sensory symptoms, like there can be blindness, like in this case. Okay, deafness may be there, paresthesias may be there. Okay, you know, hemianesthesia, peculiar very peculiar, you know, person says half side of my body I cannot feel. And of course we know anatomically you can, then there cannot be hemianesthesia, it will always be crossed. But person may say, you know, half side, exactly a half side of my body I cannot, you know, I cannot feel. So there may be sensory symptoms, there may be motor symptoms, very, you know, again very, you know, interesting. You know, patient may come with, you know, paralysis. Sir, I'm not able to move my hands or my legs or all my limbs. Or, you know, very interesting, patient may come with abnormal jerky movements, you know, which may mimic like a seizure, but they are not true seizures. Okay, they are not true seizures, these are pseudo seizures. Okay, and a lot of motor abnormalities may be there, gait abnormality may be there, you know, very peculiar type of gait. They may walk with a very wide angle gait, it may appear that they are going to fall, but they would never fall. Okay, so this is astasia abasia gait. Okay, and of course it can be mixed both as well. Okay, so some patients can have both. Okay, so there may be both sensory and motor symptoms may be there. So this is conversion disorder, this is conversion disorder. Now there is one interesting, you know, phenomena associated, you know, with such disorder, is what is la bella indifference. As you can see in this case, now imagine, you know, if any of us is not able to see for few seconds, will you be sitting comfortably? No, you will be in a very panicky state. Oh my God, what has happened? But this girl is sitting, you know, very calmly. She is not able to see, but she is very calm. This is la bella indifference, careless attitude towards serious problems or towards serious symptoms. So symptom is serious, but the person is not, you know, caring. He is indifferent to these. Person is not able to move his leg, but he is not very serious towards this symptom. Okay, so this is la bella indifference. Okay, now if you look at this question, so we know it's a conversion disorder. She's also showing la bella indifference. Now again, you know, generally these disorders, you know, conversion disorders are more common in females. Okay, more common in females than males. Now, you know, even if you don't know, you know, I understand you cannot remember everything, but if you see, you know, this question is exactly telling you the common, you know, places where it may be seen. It is giving you a case that there's a girl child, she, you know, she is having this disorder. So if you choose one, you know, still let us see. In children, incidence is equal in boys and girls. In children, incidence is more in girls. Adults, more in males. Adults, equal in males and females. Again, please remember, it is both in children as well as adults, more in females. You know, and in fact it is less likely after 35 years of age that someone would develop conversion for the first time. Generally it, you know, starts in childhood or maybe in the adolescent or early adulthood it would start. So the correct answer here is B. Okay, the correct answer is B, it is more in girl. Okay, right. So as we have discussed, it is more in females than male, both in adults as well as in children. Now again, a very interesting question, seems, you know, like a new question. I'll talk about this question again, very important. Such questions, you know, again, you know, pregnancy treatment in pregnancy of psychiatric disorder, this seems to be a very current, you know, important topic which is being asked in multiple times in, you know, in most of the exams. A mother on SSRI in pregnancy, which of the following chances increases in pregnancy? She has options are A, low APGAR score at birth, pulmonary hypertension, delayed neurodevelopmental milestones, ADHD. And most of the students say that there were multiple correct answers. Okay, so, you know, again we try to, you know, get the best recall. So it has been, you know, said that it were multiple answers. Let us try to understand SSRIs and pregnancy. You know, so we know some of the important SSRIs like sertraline, fluoxetine, okay, escitalopram, citalopram, paroxetine, vilazodone. Now in fact, you know, they are not major teratogens. You know, in fact, those who have attended my live session and even in the, you know, neuros bootcamp revision session, if you have attended, we have discussed this point. So and I, you know, discussed that, you know, such question can occur. So although they have not asked that question, but you know, they've asked question on that topic. So maybe this may be a new question. So out of all these SSRIs, which drug generally you should avoid in pregnancy? Most of these drugs we don't say are teratogens, but there is one drug. Please remember P for paroxetine. Please remember P for paroxetine. It should be avoided in pregnancy. Okay, maybe this may come as a new topic, new question. So I always use a hashtag whenever something is new or something may expect in the exam, something which is trending, we use a hashtag. So please remember this point. It may be a future MCQ. So paroxetine again should be avoided in pregnancy. It can cause teratogenic effect. It causes cardiovascular abnormalities. This is very, very important. This question may, since they they've started this, they've touched this topic of SSRIs in pregnancy, this may come as a new question. Okay, so first is this, you should know. Otherwise, a lot of patients, because you have to risk, see the risk and benefit. Sometimes just a lady having depression and she is pregnant, that depression itself may be an important problem for the child, for the growing fetus. That the fetus may have so many other problems. So that is why you have to see whether we should start SSRIs or not. And generally we say SSRIs are one of the safer medicines, some of them, of course not paroxetine. Now still SSRIs and even SNRIs, if you take, SNRIs like venlafaxine, desvenlafaxine, they may cause persistent pulmonary hypertension of the newborn. This is fairly established in many of the studies again, but the risk is not very high. The incidence is not very high. Okay, so especially in the late pregnancy, if you give the medicine in the late pregnancy, again the risk is high. So persistent pulmonary hypertension of newborn, this has been established, but again the incidence is not very high. Okay, then there are certain other abnormalities, like there may be neurodevelopmental or motor disorders, ADHD, even autism spectrum disorders, low APGAR score at birth, decreased gestational age, decreased birth weight, even gestational diabetes, okay, or preeclampsia, they may also be there. But again, this is not totally established. Okay, many of the, in fact, smaller studies, have shown these findings, but when more larger studies were done, inconclusive evidence were there in many of them. So we don't say that is a established fact, but yes, certain studies have shown that some of these abnormalities may be seen when a when a lady is pregnant, she's consuming SSRIs. Okay, so these again are controversial, not completely established, but of course has been found in certain smaller studies. Let's come to the question. So if you have to choose one answer, I'm sure now you can choose the one answer. If you had to choose, it was B, but now since multiple answers are correct and we have seen that yes, certain studies have shown that all of these can be present, so the better answer would be D, all. Okay, if you have to choose one, please remember it is persistent pulmonary hypertension. And please remember this point, paroxetine avoided in pregnancy, don't give, because it has teratogenic effect. Cardiovascular abnormalities has been shown in certain studies. Okay, so this is again pregnancy and psychiatry treatment has been asked multiple times. Now this is again a very interesting psychopharmacology question. Let us try to understand some of the important concepts. Once we understand the concept, dealing with, again, this is the best recall which we could get, so let us try to see whatever was available with us. Let us try to understand. So we have to match the class of drug and their effect. Okay, so generally we are dealing with antipsychotics. So let us try to understand. So dopamine has various paths. And when we use antipsychotics, so basically we have two types of antipsychotics. Okay, we have two types of antipsychotics. First generation or the typical antipsychotics, which we say are generally the D2 antagonist. Okay, and we have second generation or the atypicals, which are D2 and 5-HT2A antagonist. Okay, so we have these two antipsychotics. Let us try to first understand the concept. So we have four important dopamine pathways in the brain. So let's try to understand. You can remember it like this. Two pathways are there for related with the symptoms of schizophrenia, and two pathways we'll talk about, two other pathways which are more related with the side effects when we use antipsychotics. Let us talk about first these two pathways. mesolimbic pathway. Always see the name. Meso is the midbrain. So it goes from the midbrain. Which part of the midbrain? Ventral tegmental area. Okay, from the ventral tegmental area to the limbic system. It goes from this midbrain to the limbic system. Now, basically it is seen in patients with schizophrenia, there is excess of dopamine in this pathway, which leads to what is known as positive symptoms, which leads to positive symptoms of schizophrenia. So what are the positive symptoms? Like delusions, hallucinations. Okay, so delusions, hallucinations, we now know, our understanding is that it because of increase in dopamine in this pathway. Then there is another pathway, mesocortical. Again, it goes from VTA to the cortex. Which part of the cortex? To the frontal, and more specifically to the prefrontal cortex. Okay, it goes to the prefrontal cortex. And what is seen here in patients with schizophrenia, there is a decrease in dopamine in this pathway, which leads to what is known as negative symptoms of schizophrenia. It leads to negative symptoms of schizophrenia. Negative symptoms like anhedonia, avolition, affective blunting, asociality, alogia. So these are some of the negative symptoms. Okay, so this is one understanding you should know. Okay, that this is how the symptoms generally are related with the pathway. Then there are two other pathways. Let's try to understand and build some concepts. Okay, I always say in psychiatry, try to correlate things and it becomes very easy for you to remember. So next is nigrostriatal path. Okay, next is the nigro. It goes from substantia nigra to the striatum. Okay, substantia. Now basically we are using antipsychotics which are blocking the D2 receptors, which is blocking the dopamine receptor, right? Now in the nigrostriatal path. Okay, now if you know this area, substantia nigra, striatum, generally you also read in medicine, in which disorder you read it in Parkinsonism. Okay, you read it in Parkinsonism, right? Okay, or Parkinson's disease, you read about it. Now basically what happens in Parkinson's disease, in this area, what happens? There is a decrease of dopamine. That is why in the treatment we give levodopa. Okay, we give levodopa because there is a decrease of dopamine. Okay, and what kind of symptoms, if I ask you, what kind of symptoms generally occur here? Symptoms, a lot of motor symptoms like tremors, rigidity, bradykinesia, a lot of motor symptoms are there. This is about that disease. Okay, now let's try to understand, when we are giving someone dopamine antagonist, it will act on other pathways also. So please see, so in nigrostriatal pathway, when we are using antipsychotics, what they will do, they will block the D2, they are blocking the D2 receptors. There will be D2 blockage. D2 blockage will be there. Now if you can correlate what happens, in Parkinson's, there is a decrease of dopamine, it leads to certain motor symptoms. So basically what will happen is, please remember, so what will happen here is there will be EPS, extrapyramidal symptoms. So now you can understand why extrapyramidal symptoms are produced, because dopamine is getting blocked in other pathways also. Okay, so this is again one important interesting point. Okay, so please remember this. Let's talk about the last important tract, tuberoinfundibular tract. Again, it starts from basically hypothalamus, and it goes towards the infundibular, that is the anterior pituitary gland. Okay, now again let's try to understand dopamine. This has been also a physio question as well. Dopamine, let me write it here. Yeah, dopamine is inversely related with prolactin. Okay, dopamine is inversely related with prolactin. It has again been asked previously as a physio question. Okay, so if the dopamine level increases, prolactin levels will decrease. Now when we are giving antipsychotics, they are blocking D2 receptors, it will block here also. So what will happen? There will be a decrease in dopamine, and what will it produce? What will happen to the prolactin levels? There will be increase in the prolactin level. Hyperprolactinemia will be present. So if you can now understand, in females, you see, on antipsychotics, many of these antipsychotic leads to, they lead to amenorrhea, galactorrhea. Again, these are produced because of the increase in the prolactin levels. Okay, and also in males, in females and males, decreased libido, sexual side effects again may occur because of this. Okay, so this is how you can correlate. This is how, if you try to correlate, concept becomes easy. Okay, so this is important, two pathways for symptoms and two important pathways related with the side effects of antipsychotic. Now let us try to understand. So basically D2 antagonism, so when you use any drug of D2 antagonism, it will decrease the positive symptoms. Of course, we have discussed, because there is an increase of dopamine in the mesolimbic pathway which causes the positive symptoms, right? Now EPS, extrapyramidal symptoms, as we have discussed, they occur because of decrease in the dopamine in the nigrostriatal path. Okay, in the nigrostriatal path. Now please understand, in this pathway, dopamine and acetylcholine have an inverse relation. Dopamine and acetylcholine have an inverse relation. Okay, so if we use any mechanism, like any drug like M1 antagonist, that is anticholinergic drugs, what they will do? They will increase dopamine, and that is what is required, because decreased dopamine is causing EPS. So in the treatment, so you would remember, in the treatment of a lot of these like Parkinson like features of EPS, or even in acute dystonia, a lot of time we use anticholinergic drugs. This is the concept of using anticholinergic drug, right? So again, if you see, let's go back to the question. So D2 antagonism, it reduces the positive symptoms, it is correct. M1 antagonism, like anticholinergic drugs we have discussed, they reduce the EPS, very correct. Now let us talk about the other mechanisms. Now second generation, again you should, as we have discussed, second generation are D2 and 5-HT2A. Both of them are 2. 5-HT is basically serotonin. 2A, you can remember as action, mechanism of action you can remember. So they are, so it is not just D2 but 5-HT2A antagonist also. And this 5-HT2, and we also know they have less EPS. Okay, second generation antipsychotics, they have less EPS tendency than the first generation. Basically, why is this? Because this 5-HT2A, it increases dopamine. It increases dopamine, especially in certain tracts like nigrostriatal. Okay, so it decreases the EPS. So less EPS is because of this. Okay, so let us try to understand the next. So 5-HT2A antagonism, it increases dopaminergic activity, which leads to less EPS with the second generation antipsychotics. Okay, and 5-HT2C antagonism, yes, it causes weight gain. Okay, so weight gain is more with atypical drugs, atypical antipsychotic, and one of the mechanism is they have 5-HT2C antagonism. Okay, so this is the, all the options are correctly matched with the effects. Okay, so these are some of the important MCQs. Try to understand and build up concepts which will help you solve a lot of MCQs. Nowadays concept building is very important. Don't mug up. I always say in psychiatry, learn things from the name, it becomes very easy, and try to understand the concepts. Okay, and as you can see, a lot of similar questions have been asked. Okay, so try to do well. Okay, so these were some of the questions which have come in the exam, and before stopping, as I always say, keep smiling. Okay, I understand the situations, they become difficult times, preparation is there, but always keep a smile. Okay, always keep a smile, and smile will not change the circumstances, but it will change your approach. It will change the attitude by which you are approaching the exam. So always keep a smile while you are preparing. And also, as I always say, keep moving forward. This was just one exam. Exams will come and go. They are part of our life. Study and clear these exams. Keep moving forward. Don't, if you've done well, good. Have confidence and go well. If you haven't done well, then again learn from your mistakes and do well. So all the very best to all of you for all the future exams. Okay, thank you. God bless you.